Tonight we'll be discussing adult congenital heart disease and what patients wish their non-congenital physicians knew in the acute care setting. We have two guests that have been kind enough to join us this evening. Here with me in the studio is Dr. Valeria Duarte. Dr. Duarte is an adult congenital cardiologist with expertise in advanced cardiac imaging, pregnancy, and cardiovascular disease. Thanks for being here with me, Dr. Duarte.
Thank you, Ashley, always.
Joining us virtually is Amanda McElwee. Amanda has the unique experience of being both an ACHD patient and an emergency room nurse. We appreciate you joining us tonight, Amanda.
My pleasure.
And tonight we will also be sharing the story of a patient who has asked to remain anonymous. As part of that, we'll hear briefly about their diagnosis and experience as a patient in the emergency room. We want tonight to be interactive, so please send us questions and we'll address them as we move through the program. All you have to do is text DeBakey to the phone number 37607. That's DEBAKEY to 37607, and we'll be sure to answer your questions. We'd like to start off tonight by hearing a little bit from our anonymous patient, just a little bit about their diagnosis and some symptoms that they experience. DeBakey to the phone number 37607.
So let me start by talking about my diagnosis. So I do have Epstein anomaly, and in my case, I have tricuspid regurgitation. I have a dilated right atrium and a dilated right ventricle. I also have a bit of mitral regurgitation. And then also in the past, and the reason I say past is because it was repaired, I had atrial septal defect. So it was repaired through robotic surgery with a pericardial patch. It was a rather large one. It was about 2.5 by 1.5 centimeter. And in that surgery too, I had chiro ablation of the right atrium. Going back to my diagnosis and symptoms, today, before the surgery, I could tolerate activity rather well. I did have symptoms, which is shortness of breath. My activity was not that great in terms of I get tired easily, or I got tired easily, and then I could have a lot of migraines since childhood. Actually, I had several migraines. Just about every week I had a couple or so migraines.
Now, Amanda, would you be able to tell us a little bit about your diagnosis and maybe some of the symptoms that you have had as a patient?
Well, for my mom, around 10 days old, our pediatrician, who was our primary care doctor in Gulfway, Texas, which is a little small town in the middle of Texas, diagnosed me with a murmur. And so I was sent to TCH, and Dr. Nihill was the physician that took care of me, which was really cool because when my first daughter was born, she also had a ventral septal defect, which is my condition that I have. And he diagnosed me with that. And I have been very lucky because my VSD was small. My brother, who is 1 year and 5 days younger than me, was diagnosed also around 4 months old with an atrial septal defect, which we were told was uncommon because they didn't at the time think it was hereditary, and I'm in my early 40s. And he also was seen by Dr. Nihill. So, but Dr. Nihill took care of Lisa, my daughter, until she was cleared when her VSD was closed around 2 years old. So with my VSD, I really didn't have any problems with it. I was an athlete in high school. I ran cross country, and when I was probably, I guess my freshman year in high school, was diagnosed with exercise-induced asthma because I would run a couple miles and I would just get so winded. But I still kept running, and I'm a farm girl, so I've always worked outside in, out in the fields, building fence, plowing fields, doing all of it all through high school until I went to college, and ultimately now I'm a nurse, and so I'm still doing everything still. But with my VSD, it really decided to show its ugly face when I was pregnant with my last daughter, who was born. She was born almost 5 years ago, and she's my third. The only one I really had, or we noticed that I had really bad complications with, and the symptoms that it presented with was I was just so short of breath. And I didn't realize how short of breath I was getting until I'm in the ER, and my coworkers are like, "Are you okay?" And I'm like, "No, I'm not. I'm fine. I'm good. I'm just pregnant. It's all the pregnancy problems." And we'd check my heart rate, and it would be in the 130s, 140s all the time. And we couldn't quite figure out why. And I felt like I was just like coughing all the time and fluid overloaded, basically is what I learned it came down to. And I was seen by Dr. Vince Wynn at Houston Methodist Clear Lake, who also got me through my second pregnancy. And he had referred me to Dr. Lynn. So I had both of my other children at UTMB in Galveston, and I loved my OB doctor there. And she told me flat out, if you have this baby here, you may have $1 million bill. So you might want to check with Methodist. So we got referred to Dr. Lynn, and he hooked me up with Dr. Pirix, and they got me through my delivery of Mary Louise, who is also a congenital heart baby, who was born with a PFO and also a VSD. And for her follow-up, she was seen at Texas Children's. And she really, the only symptoms we had with her was when she was a baby, she had a couple ER visits because of bronchiectasis, but she would turn purple on me. And I think once the VSD closed, then that kind of stopped. But I believe her last ER visit to Texas Children's with her turning colors was about 18 months old. So we've all, I never really had issues like that. I don't think my mother didn't really tell me much about that, but my daughter for sure did. And it was really scary as a parent to see when you're, and especially me as an emergency room nurse. I work at Houston Methodist Clear Lake, and I'm a emergency room nurse. I'm also an educator. I teach certification for emergency nursing review courses. I'm also a sexual assault nurse, and I have certification in as a CCRN for ICU, and a certification in emergency nursing, as well as my certification in sexual assault. So I've got a lot of knowledge behind me, and too much knowledge is a bad thing when you have a baby with a congenital heart defect and when yourself has a congenital heart defect. But for now, the only things I deal with on a regular basis with it, and we're making, I don't know if this is really related to VSD, but I'm dealing with fluid overload, and it's pretty much maintained well through diuretics and watching my diet well. So I haven't had any significant issues. The other patient had mentioned that they had migraines, and after I had my second daughter, I had a migraine that took out memory for me for 3 hours, and short-term memory. And I didn't know it was migraine. We thought it was a stroke, so had hospitalization for that. And it showed up about 4 weeks after delivering Mary, or Lisa. And then I've had one other ER spell where I've had a migraine that presented like a stroke, where it took out my left side. And I had left-sided weakness and ataxia and a little bit of confusion with it. So it's pretty scary. I don't know if that's really VSD related. Maybe it can be. I do have retrograde flow, and I'm not on any blood thinners or anything like that. So, but that's what I've experienced so far in the past. with my VSD.
Okay. Well, we appreciate you sharing for sure. It's great to have that backstory to really kind of go forward and have the discussion about the things that are important for caregivers to know for sure. Now, Dr. Duarte, our first patient talked about Epstein's anomaly and Amanda talked about VSD. So what diagnoses is it really important, or most important, I should say, for a care team to know, to be aware of when a patient presents to the hospital?
Yes, so that's a great question, Ashley. I always tell my patients that they need to know more about their heart condition than any of us, because they are their own advocates when, especially in these emergency settings. So what we try for them to know is their diagnosis. We practice in clinic with some of them. You know, we have patients like Amanda that are very well versed and have all these, as healthcare providers, have all this knowledge. But then we have patients that do other things with their lives, so the medical terms sometimes are very challenging for them. So usually we try, if you ever have to go to an emergency room, we're traveling, and they ask you, what's your medical history? What are you going to say about your heart? And then I always like them to have a few words or a label, a definition. And then for some cases that, like to your point, that they need to know some specifics. There are some congenital heart defects that have had operations using the vessels that supply one of the arms, so the blood pressure readings may not be accurate on one side. So I do try to explain that to them. Also, the pulse sometimes is not reliable on one of their arms. So they need to know about their own oxygen saturations, because we have some patients that have oxygen saturations that are very, very low, and that's their baseline. So we just try to avoid reactions to baseline conditions that they have. Another thing, there are patients that have EKGs that at baseline look pretty abnormal, so I encourage them to have a picture of their EKG with them. Also, what we're trying to avoid is the care team to react to this unknown patient with concerning features like low blood pressure in one arm, pulse that is difficult to identify, an EKG that looks abnormal, just by providing them information about the baseline. And sometimes it's only the patient and the family are the ones that can provide this until they can reach out to us. And we have some other tools that I think Ashley is going to highlight later on, correct?
Yep. So now we've heard about a couple diagnoses, we've heard about some symptoms. Now let's hear from our anonymous patient about a specific instance where she had needed to present to the ER and kind of how that experience went for her.
There was a day I was at work, sitting in my office doing work on the computer, and I started to feel just besides myself. Things just didn't feel right. I started to feel faint. I got a lot of some blurry vision. And actually, let me say, prior to that, a few days prior to that, I could tell that generally I was more tired than my normal. Again, because of Epstein anomaly, I tend to get tired, but this is easily, but this was more just in general. I was feeling tired. And then I also had, on that day, as I was sitting in my office, I had some palpitations, arrhythmia. And so the situations continued to progress, and it got to a point actually where I felt like I was almost passing out, because again, as I said, I was sitting down, but things began to just get blurry, and I really felt very faint. And at that time, I knew it was time to call for help. And so I'd actually called somebody, and I was having a conversation and asked him, hey, just sit there with me for a minute. And we were she would intermittently ask me a question or two, and I could tell I was getting out of it. So we called the paramedic, and the paramedic get there, and then inevitably, as a congenital heart patient, as you're going through your medical history, I did let them know that I do have a heart condition, and I have Epstein anomaly. And I think when I see that, I could just see a blank, because they were not very familiar with what that is. And I really appreciated that they said, tell us more about that situation, or inquired to understand what it was. And so I did try to explain it in general terms, that my heart is enlarged on one side. I do have my deoxygenated and oxygenated blood mixing, because my valve is dislocated and it doesn't close properly. So there's some flow back, we call it regurgitation, and so it's that's what the Epstein anomaly is really characterized by. And so when I said that, obviously they had checked my oxygen levels, double checked them, they looked good. The closest hospital to my workplace, my cardiology is not the hospital system that my cardiology is at. My cardiology is at a location that is actually closer to my home. So after a little while, when I was, stable, if you will, I chose to go to the hospital that was slightly farther from my workplace, but like I said, closer to my home. But that's where my cardiologist was. And the reason I also chose that was because I felt that they already would have had access to my files. And it was easy if there was any need that arose from a heart perspective. Heading to the ER, we had called ahead to my cardiologist office, so they knew that that I was heading to the ER. I just told them, in brief, that I'm heading to the ER. So with that episode, it turns out that I needed a blood transfusion. So my blood levels were really, really low. I should not have been walking. With coordination with my cardiologist office, I had a 1.5 day stay at the hospital, just to monitor and make sure that everything was still going well.
Now, Amanda, have you had any similar experiences where you've had to present to the ER with any of your symptoms? I know obviously you've been in the ER and had some symptoms, but have you ever actually had to go from home and actually be a patient in your ER?
Well, I have actually been a patient in my ER. I'll never forget that. That was a day where I was working triage, and Dr. Wynn told me that I needed to check in because he thought that I had a blood clot or pulmonary hypertension, which as a CCRN scared the crap out of me. And so we were in our DNV survey too, so that was really fun, telling my boss, hey, I have to check in. But I was, at the time, I was also pregnant at the time, early second trimester, and I did get a CT scan for a PE as a pregnant woman, so that was kind of scary as a mom. But we were worried because the echo I had done just before showed that my pulmonary pressures were extremely elevated. And we didn't find out until while I was pregnant with Mary, during 33 weeks pregnant, I had a right heart cath with no drugs, no sedation, no IV, which I don't think Dr. Ash appreciated. But we found out that my pressures were normal. And I still remember to the day, like laying on the table in cath lab and seeing that balloon wedge pressure and just like almost bursting into tears. I was so happy that I didn't have pulmonary hypertension. And I wasn't going to have to be on a transplant list in my future. So it's very traumatizing. But I have had one ER visit since, and at the time before Mary Louise, I didn't know, I guess there's some new research that had been out that patients with open septal defects like a PFO, VSD, or ASD required like an inline IV filter that could capture air or any particles. That way it could be stroke prevention. And so the only other ER visit that I've had, I presented with, I had worked pretty much 4 night shifts in a row, had been up the day before, like worn myself completely out, had a severe migraine, and it kind of took out, that's the one that took out my left side that presented like a stroke. It was very scary. I was so out of it and scared that I didn't think at all to tell my provider that I needed this filter. But what they did see on my medical history was that I had a history of right heart failure with the VSD during pregnancy. And so they didn't, thankfully, like shoot me full of fluid or, you know, give me anything IV wise other than just contrast for the MRI and CT. But by the time we did the MRI in the hospital, they had a filter. But I was so out of it, I couldn't even tell my provider that, hey, I need this filter to prevent me from having a stroke. And as an emergency room nurse, I've actually had a very young patient in her very early 20s, not to give HIPAA info out, come to see me, and she had a stroke after medical treatment. And she had a PFO, and it was that was the first time I'd ever seen it, and it had affected her life for the rest of her life. And it was so sad because she was so young, extremely intelligent girl, and all she had was this undiagnosed PFO that got diagnosed with her stroke. And if she would have had that filter, who knows? And I don't know. So that's the scary thing for me. Like if something happens as an emergency room nurse, we get a code or we get a patient coming in who's unresponsive or altered or having stroke-like symptoms. We don't always first line look at medical history. We try to. I know the providers do, thank God. But we as nurses, we're like hands on deck. We're trying to save lives. But if I get that patient, like if I get me and, you know, I'm trying to shoot me full of IV fluids and I just screw up and get the little air bubbles, which happens frequently in nursing, you know, I could provide myself a stroke or whatever. Or like that patient, the anonymous patient that has all these complications with the right heart enlargement. You know, I'm sure that patient is like super problematic with fluids. Like you don't want to fluid overload this patient or you might even kill her. So, or him or whoever it is that our anonymous patient is. So it's kind of scary because, you know, like, and I work for Methodist system and I have to educate people all the time just about the one little thing that I need and nobody knows about it. So other than my care team with the DeBakey group or occasionally people that I've educated in the past. So I always try to tell people, you know, but like I said, that one emergency room visit that I had, I was so out of it that I couldn't, and that's, my husband was with me, but, you know, he wasn't thinking about that either. He was just like, what's wrong with my wife, you know? So I've been lucky and not having to have any other emergency visits. And I wasn't a Methodist ER. I wasn't at mine. I would have gone to mine, but I like to try not to mix my medical condition with my coworkers. But I would in a heartbeat if I was dying right there. But, so that's really the only story I have with that.
So it's interesting that you mentioned the filter because, you know, when I do education with patients in the office, that's one thing I always talk about. I actually have a filter that I carry around with me that I actually show them to show them. And I, you know, obviously there are many different filters made by many different manufacturers. They all look different, but at least so they can get an idea of this is what it should at least kind of look like. And I know, you know, we do provide a lot of education in the outpatient setting. And, you know, Dr. Duarte, do you feel like that really has an effect on how our patients interact with their care team as they go onto the acute care side?
Yes, absolutely, Ashley. I think education is critical. I think whether patients know about what special needs they have, special precautions, things that can be false positives for them in testing or tests, or exam features that in their case don't mean the same thing as in the general population. Things like that are very important for them to know. So I think the more they understand about what's going on, the better they can communicate and advocate for themselves when they find themselves in these situations where maybe there is no time to request records and get the information. The other critical thing that we try to highlight in our office visits is have them have our phone number, the contact number for our teams, so the medical teams that are caring for them can reach out to us, and sometimes a phone conversation can help fill in the gaps and guide therapy too.
And as we educate, these patients, I know we really try to drive home, if you're feeling sick and then you need to go to your closest ER, though we'd love to have, them always come to our ER. A lot of times that isn't feasible because of distance. So, these patients now are going to their closest ER. How important is it that every time they go to that ER that physician picks up the phone and makes that phone call to our team?
I think it's very important, and it's our job as their primary team to be responsive to those calls and generate relationships with the other hospitals in the region. Like you highlighted, it's important that if patients are feeling ill and acutely decompensated, they should get the best care they can get is the fastest care. So they should go to the nearest emergency room, where vitals can be assessed and initial resuscitation or what give you if needed can take place, and then they can communicate with us, and we have done this before. We can work as a team and collaborate, and once they're more stable for transportation, they can be transported to us if needed in an ambulance with appropriate personnel who can assist them during transit, as opposed to driving themselves or having a family member doing that. Some patients live quite far away from us, so it's not safe for somebody that is feeling ill to drive all the way here. I think first they need to be assessed by another healthcare provider and stabilized, and then a plan needs to be discussed amongst teams, and then we can go from there. But yes, I always tell them arrhythmias are very frequent for our patients, so and sometimes they are acutely ill and they feel dizzy and feel like they're passing out. So I don't want them behind the wheel in those circumstances, no matter how important they feel it is to get here. I think their local health providers can definitely help them out with the first steps, and then we can work together and design a plan.
And in outpatient education, as we're educating patients in the office, we talk a lot about, as you said, knowing what their baseline EKG looks like, having that picture. I usually suggest that a patient keeps a binder with their most recent MRI results and echo results and whatever is going to help them when they show up in that outside ER. I know we also have patients who keep like a thumb drive of their medical records. My chart that is available in a lot of institutions is really great. The ACHA has a patient passport that a lot of our patients utilize. So I do think that really having patients that are engaged in their care is so important, and really understanding their diagnosis, which of course for some of our patients, our younger patients especially, can be difficult. difficult.
Absolutely.
You know, as we talk about transition and moving into our program from like a pediatric program, I think is it can be a big change in that sense.
Yes, yes.
So how else do you think our kind of outpatient education really can dovetail with when they show up in the ER?
I think, like you said, having those tools like the ACHA passport, I think is very helpful. The thumb drive. So our younger patients, they really like the cell phone, so they are very good at keep having one of those cloud accounts with a document folder or a folder in their phone on their phones with pictures of notes and EKGs. I think technology really helps with that these days. In the past, patients would carry these big, books of clinical notes, but now they can have a summary on their cell phone. So I think technology has helped that a lot. And I think that our efforts need to take place every time we see the patients and we sense a need for reinforcement of education. I personally try to review the images and try to put a picture with the explanation together as we're discussing, so things start making sense and thinking, and I try to use some easy words to describe leakage and narrowing of the valves. I do try to have them know what valve is having the problem, because not all the patients are like Amanda that tells you, oh, I have a ventricular septal defect. You will have some patients that say, oh, I have a hole in my heart. And so I try to get them to elaborate a little bit on that, and in practice sometimes we repeat things while we're there, and there are some congenital histories that are very complicated, so those patients I just try them to know, have them know, okay, I have a single ventricle, I've had 4 heart operations, and then know where to find the full records to share with their provider. But I think some buzzwords to just to get the attention that they need, that what they have going on is quite complex and needs specialized care. I think that's key.
Here's a great question from the audience. If I end up in the emergency department, should my initial call be to my primary care doctor or to my cardiologist?
Amanda, do you want to take that one first?
Well, I have a wonderful PCP who is an internist at our hospital. But I feel for me, any type of communication that I've done prior to anything special or ER visit, it's always been to call the, at that point I was seeing Dr. Lynn. So letting them know, or letting the provider in the ER know, hey, you need to consult this doctor because he's part of my team. He's the one who takes care of me here at Methodist. For when I was pregnant, he was the only one, because Dr. Pirrix, yes, is in charge of the OB stuff, which is very, very important, of course. But the symptoms I was having with the tachyarrhythmia, plus the shortness of breath and the fluid overload, that was all controlled by him. So it was very important that he was part of all the decision process with my care. And I feel like that it's important for us as in the emergency room to know who those providers are for these patients, because like I work at Houston Methodist Clear Lake, which is wonderful, amazing hospital, but we don't do open heart surgery. We don't do, we will hold an LVAD to transfer to HMH when there's a bed, but we need to know, the team that we need to take you to, because if you need this emergency surgery that can wait for maybe 12 hours for a transfer to the medical center where you're in with your congenital heart team, then that's more important than you coming, going through our general surgery care and then, finding complications that we could have prevented later. So, being able to identify the patient as a congenital heart patient and knowing who takes care of them is so very important, because the provider that takes care of them should know even more in depth about their care, and they should be able to make recommendations about their care for us to save their life, or that can prevent them from having further complications that could have been prevented if we would have just known what to do the right way.
And what do you think, Dr. Duarte? Who should be that first phone call?
Yes, that's an interesting question. So I think for cardiac conditions and cardiac symptoms, definitely it should be cardiology. It's just to expedite things. I think our primary care providers are who take care of our patients. They're very well aware of their conditions and their operations and their medications and everything, and they definitely are super helpful. But I think that for cardiac conditions, then there will be a discussion with us too, and that may delay care. So I think for those, I think the most expeditious way of going about them is calling us, which is, I think, what the emergency room tends to do in those cases. And then there will be cases where the concerns are non-cardiac, and even if we get that first call, we may be calling other providers, the primary providers, the OB specialists, the general surgeons, and other people, the pulmonary doctors, hematologists involved, because we tend to work with this multidisciplinary team. So fortunately, the lines of communications are pretty effective. So I think it's just collaboration between the teams. The way it works sometimes when the cardiac defect is the main diagnosis or the main issue these patients carry, we tend to get that first call, and then we are the ones asking for help from our other subspecialists. But I think that should be left to the discretion of the provider that is taking care of the patient, and depending on what information they need. I tell my patients we are a little overbearing sometimes, so sometimes we like to know every time they get admitted, and I know that Ashley and Amanda have been working hard on making sure that our electronic medical record reflects which patients are congenital patients, so that we can get that alert, and then we can just make ourselves available for that.
Thank you both for those answers, and thank you to our audience for that question. We'll let you think of some more questions while we listen to our anonymous patient talk a little bit on kind of their post-ER visit thoughts.
It was an experience, I guess, that I've come to appreciate. The need for coordination between cardiology and paramedic and or the ER folks, and as I said, having the documents and being able to articulate, even if it's in layman terms, what your condition may be. It may not necessarily match what is being, what somebody else's perception is or what they're looking at. But that's the description of how I would explain my experience. At the end of the day, the ER doctor, right, being able to call the cardiologist and have that quick consultation helps. So I guess in a situation where I wouldn't then I've had that, the outcome may have been a bit more challenging. And obviously, I mean, having family there is obviously always a help, even though they may have their own emotions they are going through at that time. It also helps to have them there and somebody who can also articulate what your situation is in the instance that, well, I could not necessarily remember everything about the surgeries.
Now, Amanda, we heard that patient talk about coordination and communication and the ER staff really being able to reach out to their cardiologist. So how do you think in your practice, being a congenital patient kind of impacts the way you are treating those congenital patients in the ER?
Well, being a congenital patient and seeing others in the ER, it just makes me more aware that they have special needs. And I educate our staff all the time. You have to really listen to your patient. They are the best historians. They know everything about themselves. They know more about themselves than their specialists, their surgeons, anybody who takes care of them. They know more about their medicines, their daily lives, if they're actually taking their medicines, what will make them better or worse. And they know what normal is to them. So like they may come in and they look horrible to me as an ER nurse, like, oh my gosh, that doesn't look okay. Your heart rate is high. You look like you're really working. And they're like, no, I feel good right now. Actually, I'm better than I normally am. So, having to be able to, have the patient explain to the provider like what normal to them is. So I get really excited when congenital heart patients come to the ER, and I always have, and always actually excited about them in ICU back in the day, because I feel that's an education point that I learned from them, and hopefully I can help them if they have any needs that they need addressing, or that they're having issues with, maybe someone not understanding them. So I feel like really listening, reaching out to the cardiologist, having the specialist, allowing the patient to really know that they're getting the best of care in the ER setting for whatever their emergency is. If it's an ingrown toenail, or if it's unresponsiveness and we're trying to save their lives, that we have everybody on board and the coordination of care is perfect. In this world of technology, in having resources to multiple facilities, emergency visits, or facilities notes for cardiac, it's so helpful for us, but it takes so long to look all that stuff up. Your best historian is the one right in front of you. And most patients, I have friends in the congenital heart world that have had severe issues with emergency nurses, and so I really try to educate our staff at our ER to take into consideration that their normal is not yours. Like for me, I'm still terrified of getting on my elliptical, and because the last time I got on it, hardcore, my heart rate went up to 180, and it took me a while to get out of it, but that was a while back, like 4 years ago. And so I still get, just thinking of that, and knowing that, me being inactive isn't, and of course overweight, which I'm working on too, like that's my norm. My being inactive is normal for me, although I get 14,000 steps a day as an ER nurse. You'd think I'd be a beanpole. But these patients that come in, they're obese and they're struggling to breathe, there's no judgment. You can't just look at somebody and be like, okay, what's going on here? So you have to consider like what their world's really like. Like what do they do? How are they coping with having to be in this community and in this emergency room with very sick illness, and they look super sick to us and they're just a little sick to themselves, yet we are able to adequately take care of them in a manner that holistically treats them. So that's kind of my thoughts on it. I've been in a situation in the ER where the first situation where I got scanned during pregnancy the first time, and my cardiologist was speaking with the congenital heart group, and told the emergency room provider to put me on a diuretic immediately. And that provider would not do it. And it was really hard for me as an ER nurse going, okay, my doctor's telling you to do this, can you please do it? And it was 3 days later before I got to take my first dose of torsemide during pregnancy. And I can't tell you how much better I breathed, or was able to breathe after that. So it's really, I mean, the coordination is so important.
And I think you touched on something really, really important, and that's really that exchange of information, right? That even though we're the healthcare team and, the patient's coming to us for care, that we really, I think I learn more from my patients sometimes than I'm really giving back to them in education. When you really have that patient that's very engaged in their care, I mean, you're obviously a patient who understands your diagnosis and you understand the things that have happened to you. But when you have those truly engaged patients, there are so many things you can learn from them. And, I also think just every patient's different. As you said, every patient's norm is different. Their baseline is different. And I think every patient presents differently with maybe, issues that from, an MRI or a CT might look similar. Every patient kind of has their own point where they kind of tip over the edge and then need that emergency room care. So I think that's really important. And, for the healthcare providers that are watching this, I think that is a really huge take-home lesson, is that, we have to kind of push back the ego a little and, with that, and really make that kind of a on the same level playing field conversation, because we are lucky enough in congenital heart disease to have some of the most educated patients that really, really, really engage themselves. And I think, as a community, we are super lucky to be able to include those in our patients. So Dr. Duarte, from the communication standpoint, and as you're talking to your patients in the office, or then when you go to see them when they're inpatient, how do you feel like that coordination and that communication with the healthcare team kind of shifts gears when you go inpatient?
Oh, yeah. So it takes a village as an outpatient to take care of them as an outpatient and as inpatients. When you're dealing with the outpatient village, it's usually a group of providers that are familiar with the patient. And there is a lot to be said about not only knowing the history, but also knowing the baseline, like Amanda was highlighting. That it sounds like nuance, but it's just knowing that, well, their heart rate usually runs in the 60s, so now it's 108, and with their condition, these may be not very well tolerated. So even though for the general population this is not alarming, for them it may be trouble. And also knowing, well, this patient is, doesn't complain in general. Even when things are going downhill, they don't like to complain. And now they're telling you, I am fatigued and I cannot do this, and knowing their background, like, oh, they work 14,000 steps in the emergency room every day, and now they're telling you, I can just not take a shower without feeling winded. So that knowing those patients at that level, it's as helpful as knowing what the defect is and what the surgery was and all those details. So I think it's helpful for the inpatient team to hear that side of it from the patient and from the provider. and just know things that haven't worked in the past too. That's important. I used to have this patient on this antiarrhythmic, and this was the issue we had. That's why the patient is refusing it right now when you're offering it to them. So it's just tag teaming and offering our support from the advantage that we have, that is to get to know them over time, because it's a long-term relationship that we develop with them. And in the inpatient setting, as you're asking, actually the relationship is more short-term. So I think collaboration is really important, and it's two ways. It's the inpatient team asking, and our job is to be responsive to that too.
So kind of on top of that, Amanda, from the ER perspective, what do you think that we as the ACHD team can do to improve care for not only your patient, our patients as they end up in the ER, but even as they move along and become inpatients?
Well, really just to be able to fluidly transition them from emergency care to inpatient, or even to outpatient care. Just keeping up, just making sure you're aware that, if they have contacted you, I think a big thing would be follow-up. Like if you have a patient in the ER, to make sure that within the next few days they're getting a phone call from y'all's clinic staff saying, "Are you okay?" Because I think that if they were like in an outsourced hospital, like not for Methodist, or you were notified that they were there, I think follow-up is so important, because I know it's, as a patient and as an ER nurse, it's frustrating for these patients and for myself sometimes, where you get the level of care you need and you feel like symptoms are better, but then they get worse, but you're like, I'm not going through that again, or I can handle this, I can deal with this. I feel better, I think I can handle this, and I'm going on my way. So just making sure that they get a prompt follow-up, and if the issue is cardiac, a prompt full cardiac follow-up within a reasonable amount of time, so they don't worsen, or nothing that happened in the ER could have affected them worse. So I feel like that's the only thing you could really do as the congenital heart team can do to really make sure these patients are well taken care of. It's just, a follow-up.
And now that we're kind of bringing the show to a close, we'd like to present some insight from our anonymous patient on living life with adult congenital heart disease and what that means for them.
So sometimes, you get the question of, so how do you go about life with congenital heart disease? And the way I look at it is I just keep living my life to its fullest. I do it with Thanksgiving, because really, whether you have congenital heart disease or you don't, none of us are promised tomorrow. So I think it's you just go ahead and live your life. And for me, I know what my normal is, and I try and challenge myself. If, for example, I was exercising, but I also at the same time respect what my normal is and what I can tolerate physically. But at the bottom line, like I say, just live life to its fullest. And God made each of us uniquely special for a reason. And if we can just make one person smile and their life happier today, that's what it's all about, isn't it? Thank you. What I can tolerate physically. But at the bottom line, like I say, just live life to its fullest. And God made each of us.
I'd like to thank you for joining us this evening. I'd like to thank Amanda and Dr. Duarte for being here with me. And we look forward to seeing you on the next episode of DeBakey CV Live. And we hope to see you at our ACHD symposium on November 6th. Have a great night.
Thank you. Thank you, Ashley.
Thank you.